The Victorian Dual Disability Service would like to recognise the traditional owners of the country where we live, work and meet. We recognise and celebrate the diversity of Indigenous people and their enduring cultures and connections to the land and waters of Victoria. We pay our respects to elders, past and present, and recognise the Indigenous people that contribute immensely to mental health and disability services. We would also like to acknowledge the immeasurable contributions of people with a lived and living experience of mental illness, psychological distress, alcohol and other drugs, and disability, as well as those who love, have loved, and care for them. We acknowledge that each person's experience is unique and valued. We recognize their adverse experience of stigma, but also their strength and resilience. We respect and value their generous contributions, which teach us and guide us to continually shape, reflect upon, and deliver quality care from a lived experience perspective.
Welcome to this webinar. We talk about borderline personality disorder and intellectual disability. In this webinar, we hope to um, discuss and outline what borderline personality disorder and intellectual disability are, and also increase awareness of the presentation, assessment, and management overview of borderline personality disorder when coexisting with intellectual disability. So, starting with the very basics. So intellectual disability is one of the neurodevelopmental disorders, which means that it's a disorder emerges during early developmental period. And intellectual means it affects the intellectual function of the brain that includes the ability to perform in academic, social, and practical domains. And assessing the cognitive impairment requires the clinical assessment, clinical impression, and also standardized intelligence testing. That is an IQ test and with a score of 70 and below. So in DSM-5 now requires both evidence from a clinical assessment as well as standardized intelligence testing. Now, the cognitive impairment, as I've mentioned earlier, needs to emerge from early developmental period. That the cutoff is usually 18, irrespective of the cause of that cognitive impairment. And the cognitive impairment needs to be of a significant impact to affect the one's academic, social, and day-to-day functional capacity and requires ongoing support. So that's intellectual disability. We know it has a lot of impacts on people. So it affects the way they learn, they process information, and also in particular affect their abstract concepts and how they can manage money, manage public transport, and interpersonal interactions as well. Now, the kind of support and assistance they require will depend on the cognitive impairment, whether it is generalized or more specific to certain areas, and also the communication capacity. Now, those cognitive and communication difficulties can be matched with a particular environment where the expectations are limited and the level of support is too high. And in that way, they can actually flourish and feel well supported and engaged. So the expectations placed on them within a particular environment plays a major role as well. And also other factors that affect the capacity of a person with intellectual disability to function would involve any coexisting physical, developmental, or mental health conditions and disabilities as well. Because it's common for people with intellectual disability to have comorbid, coexisting disorders as well. And it affects 1 to 3% of the population, which means that it's quite common. Now, personality disorder, on the other hand, is an enduring pattern of inner experience, behavior, deviation, markedly from the expectation of individual culture, background, upbringing, and expectation. So it's from the definition of a personality disorder that it's kind of an enduring pattern. They kind of born with it and shaped by their environment, their temperament, and their life experience. So it's kind of an evolving thing that is usually shaped over the years, and usually by the time they reach maturity, that pattern becomes quite established and affect the way they kind of perceive the environment, process their emotions, interact with others, how they think about things, and the ability to function and impulse control. So it's quite persistent and pervasive pattern that happens. And it's if you think of it, is that when you know someone very well, you can predict how they will interact, what will they do in a particular situation, and that's is called their personality, their character. However, when this personality or character is out of expectation, deviate a lot from what is expected from them in terms of their cultural background, their upbringing, their beliefs, and their shared values, and all that, then it can cause a lot of distress and impairment of functioning for that person within that community. And this is important in identifying the difference between personality style, personality character, personality trait, and a personality disorder. Now, this pattern is important to be a persistent, pervasive, and part of their character, not just a reaction to an abnormal situation or a phase of a mental illness or secondary to substance use or medical problem, and so on. Hence, it's important when we assess for personality disorder that we take a longitudinal assessment of their pattern of behavior and presentation, not just in a cross-sectional manner when they are mentally unwell or under the influence of drugs or feeling unwell, because that can actually cloud the picture of the presentation. Now, the prevalence of personality disorder varies from 4 to 15% in general population, and as expected, it's much higher in clinical or forensic population. It can range from 26 to 65%. Now, DSM-5 criteria for borderline personality disorder, our focus during this webinar. It requires 5 criteria, and those criteria, if we explore them, it includes a lot of instability. So the first criteria is frantic efforts to avoid real or imagined abandonment. So that leads to a pattern of unstable, intense relationships. So they end up having a lot of recurrent relationships and they fall in love quite quickly, they get attached quite quickly, and they fear being abandoned, so they stick with that relationship even knowing that it's a bad relationship, it's an abusive relationship. And that leads to a recurrent pattern of crises when they are in a relationship and that relationship ends, or they perceive that it's going to end. They suddenly feel they are going to be abandoned, they are unable to cope, and they do a lot of frantic efforts to avoid that separation, which may include threatening suicide or self-harm, and it's that leads to recurrent episodes of suicide or self-harm. And they also, all these difficulties, these interpersonal difficulties, stems from their difficulty in kind of chronic feeling of emptiness and identity disturbance. So they have usually they have an unstable self-image or sense of self or self-worth. That also combined with a lot of impulsivity in actions and taking a lot of risks in 2 or more domains like sex, spending, reckless driving, binge eating, or substance abuse. And they also have affective instability, which means that the emotions are quite high. So they shift from feeling very happy and settled to very angry or sad and depressed. And here it's quite different to the mood instability that happens in bipolar, because affective instability is usually short-lived. While it may be quite intense, it's usually short-lived and usually not associated with other biological symptoms of depression or mania. So we're talking about more of a quick shift of emotions within a matter of minutes, hours, not the ones that extend for days or weeks or months, as you see in a mood disorder. Now, they also have inappropriate, intense anger and difficulty controlling their anger, which leads to a lot of impulsivity and recurrent physical fights. They also have transient stress-related psychotic symptoms, mostly paranoia, but it can also be hallucinations. Now, those criteria, if you think about them, they are a lot of instability. So borderline personality disorder can be called the disorder of instability, instability of affect, the emotions, where with a lot of intense anger and affective kind of instability and very quickly shifting between feeling angry, happy, and depressed. It's also unstable relationships with recurrent intense attachment, intense relationships very quickly, and then once they are in those relationships, they fear being abandoned, and they kind of also have a lot of quickly shifting views of people. Either they love them or they hate them. Either you are the best carer or you're the worst carer, and this views shifts very quickly without actually having long, stable views of things. They also have a lot of unstable sense of self, chronic feeling of emptiness, self-view, and self-worth. They have unstable cognition, a lot of impulsivity, a lot of transit psychosis, and reality testing, unrealistic expectations and plans. And they also have unstable behavior with a lot of recurrent self-harm, mutilation, suicidal, chronic suicidal thoughts, and aggression. Now, it's important to acknowledge that borderline personality disorder and intellectual disability may be associated with behavioral dysregulation. And having an intellectual disability can cloud the picture, and all those symptoms of borderline personality disorder can be attributed to intellectual disability, which leads to missing a diagnosis of a comorbid, coexisting personality disorder in people with intellectual disability. And this is we call diagnostic overshadowing. The diagnosis of intellectual disability overshadowed the personality disorder presentation. Now, how common is borderline personality disorder? It's quite common. It's 1 to 4% of the population, and as we mentioned earlier, it's actually much more prevalent in mental health settings. Can be 23% up to 60%, depending on which mental health setting you're talking about. And there is more common female to male ratio, 3 to 1. And there's a lot of gene, environment, temperament interacting with those other developmental factors and other life experiences that can shape the personality and the character of the person. So there is some suggestion of genetic predisposition, but the built-in temperament of the child and what life experiences they have, particularly history of trauma, sexual abuse, invalidating upbringing style, and all general adversities can contribute to the risk factors of developing a borderline personality disorder. Hence, it makes sense that people with intellectual disability are more predisposed to developing in borderline personality disorder because they share the neurobiological dysfunction, and they also share the psychosocial adversity. People with intellectual disability are more likely to be victims of abuse, neglect, adverse life events, and all those kind of invalidating experiences that are known to be risk factors for developing borderline personality disorder. So it's how do we kind of account for that? If we explore the risk factors of developing borderline in ID, you will find that people with ID have a higher level of assistance, and they require a lot of input and support from caregivers, which by default would increase their dependence on others, and they require a lot of invasive assistance with daily living functions, and they are less able to meet the expectations of their caregivers or parents, and they require long-term period of care, and the care they receive and the repeated loss and abandonment from moving from one family hall to the other, from one supported accommodation to the other, from one service to the other, from one carer to the other, that leads to a lot of unstable relationships, and that can also shape their views about their self-worth, self-esteem, network of support, and increase responsiveness to kind of uh, being kind of predicting high risk of invalidating experiences as well. So that all leads to increased risk of abuse, increased risk of reaction, having a reaction to adversities as well. So that brings us to, after we've discussed all those risk factors that associate intellectual disability with borderline, if you look at the literature, you will find a huge range of prevalence of borderline personality disorder in people with ID. It can range from 1% to 91% in the community, and from 22% in institutions to 92%. I know it's wide range, and that highlights the quality of those research and the criteria they used to actually clarify the diagnosis, and all those other kind of contributing factors to the uncertainty about those figures. But the take-home message is there is a definite signature of increased borderline personality disorder associated with developmental disorders, including intellectual disability. And the general consensus is that about 20 to 30% comorbidity is commonly reported. Now, the next part is the assessment. So assessing for borderline personality disorder in people with ID. And here we need to explore a few things, a few issues with that assessment. Individuals with intellectual disability are not immune to borderline personality disorder. As we've reviewed the prevalence and the risk factors and all that, it is quite clear that intellectual disability is a risk factor for developing coexisting borderline personality disorder. However, the assessment can be tricky because clinicians usually may have a lot of objections about adding an additional label that is associated with a lot of negative views from the health professional and the general population. And so they question, why do I add another stigmatizing diagnosis and a stigmatizing label to someone who's already been stigmatized by having a diagnosis of intellectual disability? Now, there are a lot of practical difficulties in assessing, clarifying the symptoms, and providing a consistent diagnosis. And the next question comes up is, so what's next if we confirm the diagnosis? Treatment of borderline personality disorder is quite difficult in general population, and it can be even more difficult in people with intellectual disability. So that adds another layer of resistance to actually making such diagnosis. So in exploring the difficulties in the assessment, exploring, if you are trying to assess and make a diagnosis of borderline personality disorder in someone with intellectual disability, what things do you need to consider? What things do you need to think about? And the first and most common one is diagnostic overshadowing, attributing the problem, the presentation to ID, or it's just all behavioral. Now, that leads to kind of it's important that the diagnostic criteria requires sophisticated cognitive and communication ability, and it's sometimes difficult to actually confirm whether they meet the criteria or not. If you take the criteria in a kind of a very rigid manner and you want to fulfill them, then someone with communication difficulties or having cognitive impairment may not be able to recognize, report, and communicate those symptoms. Hence, technically, they kind of would be excluded from that diagnosis. And that's also added to other difficulties in obtaining history, obtaining reliable, longitudinal collateral information. Most of people with ID contact with mental health is on a crisis-based, events. So it's mostly cross-sectional assessment. They don't take them on for longitudinal assessment to observe them over a period of time and gather longitudinal assessment and information from different services, because most of the time they move from one service to the other, from one provider to the other, and to gather collateral consistent assessment and information requires a lot of effort, commitment, and resources to gather all these informations. And also the lack of professional training, experience, and knowledge in mental health, in how to clarify symptoms and how to assess people with intellectual disability, particularly when they have communication impairment. And also the same applies to family and carers, with the lack of the knowledge and awareness about mental health symptoms and personality disorders in general, and how to report, well, before reporting, how to identify and then report those symptoms to health professionals. So that leads to kind of a lot of difficulty about, how to elicit symptoms and how to compare these symptoms to the DSM-5 criteria, particularly for someone with an IQ below 50, where they kind of all those symptoms can actually be overshadowed by the developmental disorders. Now, there are a lot of also issues with maturity, and in particular, we know that to make a diagnosis of personality disorder, you need the person to have reached a personality maturity, which usually in general population, we take the age of 18 as the cutoff for that. Although there's a call now to actually lower that and not to have a very rigid approach about it. So if you have a person with a persistent, pervasive pattern of character and personality that has been stable over the years, you may consider making that diagnosis as early as the age of 16. But it becomes a bit gray in people with intellectual disability, because there is some suggestion that the personal development maturity can be quite delayed. Hence, there is a general consensus that you would defer a diagnosis of personality disorder until the age of 21 in people with intellectual disability. Although you still need to be flexible. Nothing is written on stone. You need to take an individual approach to the person in front of you. So if they, as I've mentioned before, if they have a persistent pattern and pervasive that has been stable for years, even if you make a provisional diagnosis of personality disorder, that should not delay interventions, because there is some suggestion in the literature that the earlier intervention, the better outcome. Now, so behavioral assessment, which is quite common in people with intellectual disability for coexisting behavioral disorders, those behavioral assessments need to take into account the personality, keeping in mind that the behavior usually has a function. And it's not an automatic thing that someone with intellectual disability would have a behavior of concern. And it's also the other way around as well. Behaviors of concern can happen in general population, in people with mental illness, physical illness, personality disorders. So it's not something specific to people with ID, and it's not a symptom of intellectual disability. Hence, it's important to assess and widen your horizon when you are exploring the reason behind a behavior of concern, which a personality disorder could be a major contributing factor. So, challenging behaviors and personality disorder are commonly associated with each other because the function of challenging behavior may be driven by the interpersonal and the relationship difficulties, including fear of being abandoned or a kind of have a kind of frequently polarized views of their carers or people around them, that they are either being idealized and they are the best people ever, or devalued and they are the worst people ever. And that quickly shifting views can lead to challenging behavior when you are interacting with those people. And sometimes they actually may enjoy the impact or the we call it the drama that comes up with those interpersonal conflicts. Now, personality may also contribute to the frequency of behaviors of concern. With, people with borderline personality disorder have a lot of impulsivity, inappropriate anger, and a lot of affective instability. All these symptoms would definitely be associated with behaviors of concern, and it also, borderline personality disorder may actually kind of determine what type of behaviors can be associated, including aggression or targeting particular people, or looking for gaps and inconsistencies in communication or approach, and working with that to create a lot of interpersonal arguments and drama. So if you want to consider the diagnostic criteria of DSM-5, taking into account the intellectual disability, you may look at the diagnostic manual for people with intellectual disability, the second version. And with that, it tries to go through all the DSM criteria for borderline and account for and explore it with the lens of intellectual disability. So the first criteria is fear of being abandoned. Now, that criteria, you need to take into consideration intellectual disability and the level of function, the need for care from others, and depending on others for those practical and emotional needs. So it's justified for people with intellectual disability to recognize that they need others and they fear that they will be left alone. Now, how to differentiate that from fear of being abandoned? It can be tricky, it can be difficult, but in general, you need to have first good understanding of the level of functioning, in terms of cognitive functioning and the kind of practical day-to-day ability to function. And you also need to know the actual perception of that function. Many people with ID may have good understanding of their ability. However, some can actually exaggerate their self-independence. Some people can undermine those self-independence skills they have. Getting to know the person very well and getting collateral information from their people who know them very well can help you to identify whether the fear of abandonment is justified, in keeping with their personal views, in keeping with their usual presentation and understanding, or is it out of proportion. Sometimes it's possible to actually clarify that, sometimes it's not, and you need to depend on other criteria. Now, the next one is unstable relationships. So again, you need to take into consideration that people with intellectual disability may have some difficulty in understanding relationships, and they learn to behave in a particular way to meet their needs and to socialize. Sometimes they have a comorbid autism. All these can affect their ability to form and maintain relationships. Now, so at a superficial level, many people with intellectual disability do not have long-term relationships, do not sustain relationships. If you take that as a face value and say, well, this meets the DSM-5 criteria for borderline, you overdiagnose borderline personality disorder. So you need to take into account that unstable relationship. What's behind it? Is it recurrent, intense fear of abandonment coming from a lot of internal feel of self-worth that is out of proportion for the actual capacity or not? So again, a difficult criteria to meet, a difficult one to fulfill, particularly with someone with significant cognitive impairment. But you need to ask yourself those questions when you're trying to explore the criteria. Now, the splitting and is another criteria for borderline personality disorder. And again, it needs to take into account that people with ID have a lot of frustration and feel powerless around others. They have a lot of things done to them, decisions made for them without actually quite consultation, and that can kind of cloud the picture. Borderline in ID usually emerge as kind of quickly shifting views of the people with them, from idealizing them to actually devaluing them, and splitting staff and services, causing a lot of havoc and chaos around them. You told me this, they told me that, and it's not it can be, again, superficially looked at as similar to black and white thinking of someone with autism. But in borderline, it's a bit different. It's that shifting and changing very quickly. It's about the kind of looking for inconsistency in approach to use it in their advantage to get away what they want, rather than someone with autism who find it confusing, when they receive inconsistent message. So there are quite some, similarities and differences. Now, there are also identity, unstable identity, however, and chronic feeling of emptiness and shifting of views about what they like to do, and moving from one activity to the other, and changing career, changing views on the world, changing views about what they want to do in life, and all that. This requires kind of sophisticated cognition and communication capacity to report on that. And it also can be difficult to differentiate from coexisting ADHD as well, which is quite common in people with intellectual disability. But again, it may present as I said, changing career, changing hobbies, changing timetables and routines quickly, and getting bored quite quickly, and also associated with kind of negative views of oneself. Now, impulsivity is another criteria of borderline, but it's quite common in people with intellectual disability, autism, ADHD, all those other developmental disorders. And here it's important to acknowledge that it's impulsivity and risk taking despite knowing the consequences, which may not be quite clear in people with ID or significant cognitive impairment. Hence, this criteria can be actually difficult to differentiate between the two, and needs to be taken into account very clearly, that is out of keeping, out of what is expected from their baseline developmental disorder. Now, recurrent suicidal thoughts and self-harm can also be difficult to differentiate with ID, because self-interest behavior is quite common in people with ID and ASD as well. However, the self-interest behavior in ID or ASD can be considered as self-stimulatory, while in borderline personality disorder is more about managing the emotional distress. It's about it's coming from the chronic low self-esteem, chronic poor self-image, feeling of emptiness, and it's usually around crisis time that escalates. And so if you are able to clarify that, that may help you differentiate between the two. Now, affective instability also is one of the major criteria for borderline personality disorder, and that can also be challenging with the dysregulation and distress that happens with people with intellectual disability or autism, particularly, although the triggers can be quite different. So in someone with autism, they may have meltdowns when there are unexpected changes to their routine, being sensory overstimulated or overwhelmed by social demands, communication difficulties, sensory inputs. So the triggers are usually different, although the cross-sectional presentation may mimic affective dysregulation. However, affective instability around the views of others, around the perceived abandonment, about interpersonal interactions are usually more specific to borderline personality disorder. Now, anger, inappropriate anger, and risk taking can also be quite common in people with ID because of their lack of understanding of consequences, and sometimes they use that as a behavior of concern and as a means of avoiding tasks, avoiding certain environments, or even achieving a desired outcome. And borderline, that's different. That's part of their character, their personality, and it's about engaging in other activities that has a high risk involved, like using drugs, engaging in unprotected sex, and of spending, and things that help them to achieve kind of a reward system or novelty. Now, transient psychotic symptoms, it's also another criteria for borderline, and it's quite clear that it emerges during those highly stressful situations, usually around relationship ending or fear or perceived loss or abandonment, and other interpersonal issues. That's usually, if it's confirmed psychotic symptoms, that cannot be considered as part of ID. However, sometimes when people with intellectual disability, if they are placed in a situation that overwhelms them and exceeds their capacity, their cognitive capacity to think and understand and communicate what's going on with them, they may present with a very disorganized manner. We call it cognitive disintegration. And if you look at it in a very brief cross-sectional manner, you may think they are psychotic. However, collateral history will clarify that this is how they present when they are placed in that particular situation, and usually that resolves very quickly once they are out of that scenario, and that can help you to differentiate between psychotic symptoms and just disintegration. All these features of borderline can mimic behaviors and presentations in people with ID. So how do we differentiate between the two? What are the kind of commonly defining features that helps you to differentiate the two? Well, first of all, extreme changes in affect are out of proportion for the environmental factors and difficult to support. That is not in keeping with the usual presentation, not in keeping with the cognitive and functional capacity, and out of proportion to that particular environment, particularly when it is associated with the usual borderline personality triggers: perceived loss, abandonment, and those related to interpersonal relationships. Now, the other one is the a case where they always look for loopholes and can be perceived as a manipulative behavior. You told me this, they told me that. You gave me this, they didn't give me that. I'm expecting the same as that, and work and creating that kind of chaos and havoc around different carers and different services. That's usually an indication that that could be a coexisting borderline personality disorder. So and splitting, favoring one staff to the other, quickly shifting views of staff and others. You are the best, and then the next day you are the worst, and it's all kind of not based on actually a significant change in approach. It's just how they feel on the day, how they feel about people giving in to their demands or not, and also having a lot of subjective perception of victimization, that they all perceive themselves as the victim, and that they have a lot of impulsive pattern of self-destructive behavior that is not in keeping with the usual triggers for autism associated or intellectual disability or things like that. And also the stress related paranoia and hallucinations are usually another differentiating factor. Sometimes it can be quite clear. Many times it's difficult to actually clarify, particularly when you're doing a cross-sectional assessment. Hence, it's important to actually conduct a longitudinal assessment, and we will discuss that in a minute. Now, regarding suicide and self-harm, suicide in people with borderline in coexisting with intellectual disability, usually it's quite two types. There are the chronic feeling, passive thoughts about and wishes of being dead, that doesn't come up with quite a clear plan or intent. It's just kind of having kind of that need for being rescued, the need for being looked after. On top of that, they can also develop acute suicidal thoughts with clear plan and intention, and sometimes even actions. So it's important to differentiate between the baseline chronic suicidal thoughts, suicidal feelings, suicidal environment around them, and the acute plan that comes on top of the chronic one. The acute one needs immediate action to ensure safety. The chronic one needs ongoing management. So, and also you need to identify what are the usual triggers to shift the person from having their baseline chronic suicidal thoughts to having an acute suicidal plan and intent. And that usually revolves around feeling abandoned, or an end of relationship, or feeling the loss of kind of a carer or a support person. Suicide is quite common in people with borderline personality disorder, and around 8 to 10% do complete suicide. And it's quite difficult to predict when they will shift from the chronic to the acute, and how to differentiate between the two. And again, having a good longitudinal assessment and having a good understanding of their baseline and referring to their current presentation can help you differentiate between the two. Now, self-harm or self-injurious behavior is those actions that are not intended to commit suicide. Is usually a self-injurious behavior. It occurs in 50 to 80% of people with borderline. It's usually triggered by all those negative emotions that they have about separation and loss, and it can be considered as their mean to cope with those negative emotions. Sometimes they report that they do it because it gives them distraction. Sometimes they report they do it because it makes them feel better for a split second, but usually it's followed by feeling ashamed and feeling even worse afterwards. Sometimes they report that they do it to feel something, because they usually feel numb and empty. Sometimes they engage in self-harm to actually feel something, have some emotions. So there are a lot of reasons behind it, and exploring those can help identify the kind of the usual triggers and mechanism behind it. Although it can also be biologically driven, because self-harm and help release internal endorphins, and that can actually make them feel numb or even high for a short period of time, and that can increase the pain threshold, and that leads to kind of a vicious cycle, and it can even be considered as an addictive cycle of self-harm and endorphin interaction. Now, so with all these issues that we have to consider, we come to the assessment part with with some considerations. We need to be aware of the double stigma of having a diagnosis of intellectual disability and borderline, and that some services use that as an excuse to exclude people from from services. And it's also important for people with to acknowledge that people with ID are one of the most marginalized people in society. So adding another layer of stigma and another barrier to accessing service can actually be harmful. However, it's important to acknowledge that recognizing borderline personality disorder in someone with intellectual disability can have a lot of advantages. That includes receiving appropriate support, more targeted interventions, and also help you as a carer, help you as a health professional, and help the person as well to understand why they are acting in that way. It's not to get back at you, it's not to annoy you, it's just this is how they interact with others, how they perceive the interaction with others. And that understanding can actually be enlightening to many people and help them to understand more about themselves, help them to understand more about their client, and provide a more kind of meaningful interaction. It's help them to actually identify the reason why that person acted that way and how to actually avoid the triggers as well. So, but it's in general, people with moderate or severe ID, it's quite difficult to actually clarify the criteria for borderline. Hence, the diagnosis can be actually quite difficult and tricky. Um, Now, the assessment process. So, the assessment process may follow a suggested framework called the LEAD, which emphasize longitudinal assessment, not cross-sectional assessment, not jumping into conclusion when a person with ID presenting to ED after self-harm and appearing to have a lot of high emotions and distress and anger and impulsivity, and then suddenly he or she receives the diagnosis of borderline. Borderline is a persistent, pervasive pattern of behavior, emotions, and cognition, and all and interpersonal reaction. So you need to have longitudinal assessment that involves longitudinal gathering of information, longitudinal reports, and also ongoing longitudinal assessment at different times. And so that's the L part of the lead. The E part is the expert, where you need to have a consistency of experienced clinicians agreeing on their same views, because we know sometimes particular people do have a kind of a strong reaction, strong views about a particular symptom or particular presentation in our patients. So that interpersonal conflict can cloud our judgment sometimes, and we may use the term borderline personality as kind of a justification why we feel bad about some patient or some behavior. So it's important to actually be objective, involve a team around you in observing and assessing and exploring all the information, and come up with a consistent approach to the diagnosis that takes into consideration all the data available. So how they presented at baseline, how they presented over the years, how they interacted with others, and the impact of mental illness, organic issues, drug and alcohol abuse, and all those different contributing factors. And evaluating all that over a longitudinal manner can help you provide a comprehensive mental health assessment that is more consistent with clarifying the diagnosis. Now, there are some assessment instruments that can be used. Screening one, like the standardized assessment of personality, the abbreviated scale. Those are quite, can be used as screening tools. They're quite sensitive, but they're not specific, and they're not kind of validated for comorbidities as well. So they need to be all these factors need to be taken into account. There are also other kind of structured or semi-structured interviews, like the SCID, which can help you to elicit and can help you to clarify the presentation and can help with the assessment. However, it's All these tools do have their advantages and disadvantages, and inter-rater stability and correlation is not that great. Hence, the golden standard remains in the clinical assessment, particularly the longitudinal one against DSM or ICD diagnostic criteria. And with that, I come to the end of the first part of this webinar, and I will hand you over now to Andrew Pridding, our nurse practitioner, to talk to you more about the management of borderline personality disorder in people with intellectual disability. Thank you for listening.
Thank you, Tareq. So I'm going to give a brief overview of treatment and management for borderline personality disorder in people with an intellectual disability. To start off with, people with intellectual disability and borderline personality disorder can be highly complex, and they can present significant challenges to those trying to support them. One of the difficulties is they're usually the most complex people being supported by carers with the least experience or expertise. And there's difficulty describing interventions that are going to be of assistance because of the lack of evidence in relation to treatment and management of this group. And some people have described it like walking through thick fog, where it's difficult to know which way to go, but any guidance is welcome. The evidence is limited, particularly on treatment and management. Most of the evidence that's available seems to be mostly related to assessment and diagnosis. And it's really not clear from the published literature about what would constitute an effective intervention. So that means that treatment and management strategies are predominantly extrapolated from evidence in the general population. And it's not really that clear whether those interventions would be applicable or effective. When you look at what's recommended for people with borderline personality disorder in general, psychosocial interventions are recommended as the primary treatment for personality disorder, with pharmacotherapy as an adjunct to that treatment. And that would be the same for people with an intellectual disability. However, what you tend to find is a dependence on psychotropic medication as the main form of intervention in this population, and very limited amounts of psychosocial interventions being applied. In terms of those psychosocial interventions that have been described, a systematic review in 2008 identified only 3 papers on non-pharmacological interventions for people with an intellectual disability. And 10 years later, there were only a further 8 studies identified. All of those studies provided weak research evidence, littered with methodological flaws, and so findings should be treated with caution. In terms of guidelines, there are some guidelines in relation to intellectual disability and personality disorder. There's a published book edited by Webb that provides a description of clinicians' practical experiences, and that can provide some practical guidance to management. The guidelines that are being published for people with borderline personality in general, the guidelines from Australia, for the NHMRC guidelines from 2012, are largely silent on the issue of intellectual disability, except to say that the literature is very limited. The National Institute of Clinical Excellence from the UK do address the issue in a bit more detail. So they recommend that for people with borderline personality disorder and mild intellectual disability, they should receive access to the same services as other people with borderline personality disorder, and that there should be a structured approach, and that in all cases they should seek specialist consultation from services with expertise in the management of people with an intellectual disability. Those guidelines do, however, also state that in most cases, people with moderate or more severe intellectual disability would not normally be diagnosed with a personality disorder. And so therefore, it's not possible to provide recommendation on treatment and management. So the evidence and guidelines, as I mentioned, are quite limited. And there are a number of challenges. So finding appropriately skilled therapists is difficult. People may not fit standard treatment programs if you're using treatment as usual. There are practical complications in terms of cost. Many people with intellectual disability have limited funds and would rely on other people to access services on their behalf. Transport is often difficult, and there's a need often for carers to attend interventions with the person so that they can feed back to other parts of the support team, and also so they can assist the person to be able to implement some of those interventions in real life settings. The lack of clinical policies, pathways, or guidelines at both national and state level continues to be a challenge. And there's significant issues with diagnostic overshadowing, whereby everything is attributed to the intellectual disability, and that therefore overshadows the possible presence of a borderline personality disorder, and therefore the person doesn't receive interventions specific to that disorder. On top of that, there's a significant degree of therapeutic nihilism. So the opinion that people with an intellectual disability cannot benefit from the usual psychological interventions that someone without a disability would be able to engage in. And therefore, there is no point engaging them or offering that service because they can't participate and it wouldn't be workable. And that leads to a considerable level of exclusion. There's also the stigma of having a disability, and for some services, quite over enthusiastic gatekeeping in terms of, well, these people don't meet our criteria, so therefore they can't access the services. So what do we recommend then when seeking to try and provide some input for an individual with borderline personality disorder and intellectual disability? Well, I think there's some general principles that can be extrapolated both from clinical experience and from the limited available literature. To be effective, services need to work together in collaboration, and there needs to be a structured approach. There needs to be shared understanding between service providers about the management plan, and there needs to be a degree of consistency in application of management. There needs to be an agreement about the diagnosis, and try to avoid multiple repeat assessments and referrals, whereby there's a continual cycle through different assessments and referrals, trying to seek additional clarification. I think once you've got a fair degree of confidence and agreement about that diagnosis, then it's time to move on and provide intervention rather than seeking further assessments. There needs to be a clear management plan and a risk assessment that provides guidance to the person and their support networks about how to keep themselves safe, clear boundaries that can be maintained, a biopsychosocial approach that includes the person and their support networks in development of plans. Staff need to be appropriately trained and supported. There's a very high degree of burnout amongst people supporting those with BPD and ID, and they need a significant amount of support and appropriate supervision. There's also needs to be clear staff roles and responsibilities and an identified governance structure. So a number of principles that can be applied to most successful plans. So bearing that in mind, when looking at management planning, as I've just described, a biopsychosocial approach is the recommended approach, and that should be informed by a comprehensive assessment. It should be conducted in collaboration with the person and their support networks and provide information in an accessible form that the person can understand and also their support networks can understand. And that management planning should also address risk, crisis support and response. And those are issues that are often missing from the management plan. Where possible, it's good to refer to generic or intellectual disability specific guidelines. And there are some guidelines that provide generic information on management of people with intellectual disability and concurrent mental health problems. And that can be quite useful in designing a good management plan. In terms of going through the biopsychosocial approach, in terms of biological or pharmacological interventions, it's really important to recognize that this is a group where there are significant amounts of unrecognized or poorly managed medical issues, including dental problems. So people may be in pain or significant discomfort, or they may have conditions that haven't previously been identified, and these need to be identified and, where possible, adequately addressed. And that would be a priority and one of the first things you would look at. There are also high rates of psychotropic prescribing, usually antipsychotics, often off-label and in significantly higher dosages and in different combinations than would generally be seen as useful. Many of these treatment strategies would have no clear target and limited monitoring or evaluation and a limited plan about how they're going to be evaluated. So what we would recommend is treatment as usual for clear concurrent mental health problems. So if someone's got depression and they would normally be receiving an antidepressant as part of their treatment plan, then you would adopt the same approach for someone with BPD and ID. If they have psychotic symptoms, then you would prescribe an antipsychotic, but look at reducing and ceasing the medication when it was no longer required. And so adopt the same principles as you would for any person with a comorbid mental health issue. In terms of specific approaches to borderline personality disorder, we'd advise the same principles as for the general population. There's no one clear labeled medication, but there are some medications that can be helpful for some aspects of borderline personality disorder, although it would be necessary to recognize that those would constitute restrictive practices and interventions under the NDS rules and the Victorian Disability Act. So when prescribing, it would help medication can help to manage specific symptoms or to improve the person's cooperation with non-pharmacological management. So a good example would be some people find that a low dose of an antipsychotic can reduce their arousal sufficiently to enable them to engage in non-pharmacological interventions when they wouldn't otherwise be able to do so. Other examples could include consideration of some mood stabilizers, such as lamotrigine or valproate for emotional instability, and also to consider antipsychotics for management of irritability, and particularly if there's comorbid autism, risperidone can be quite useful in a short-term reduction of irritability and agitation that will allow other interventions to be feasible. It's very important to have a clear target for treatment and a plan for evaluation, as I discussed in the previous slide, and a time frame about when those treatment approaches are going to be evaluated and when you would consider withdrawing the medication. I'd recommend exercising caution because this is a population who can exhibit unpredictable responses or atypical reactions to medications. And they can often have significant communication impairments. That means they're not able to communicate adverse effects or undesirable effects they also have a very limited capacity to stop their own medication. So if someone without an intellectual disability found that they were experiencing adverse effects from their medication, they would usually just stop taking it. For someone with an intellectual disability, that medication is usually administered to them, and they don't have that option, and they aren't always able to communicate that there's something wrong. So the approach we would recommend is to start low, go slow, monitor and evaluate, change or add one agent at a time, and withdraw if that intervention is ineffective or poorly tolerated. And there is a real lack of psychoeducation around medication and prescribing. And so it's important to provide details to the person and their support network in a format that they can understand. So providing the usual consumer medication information to someone with a significant cognitive impairment who may not have good reading skills or may not have any literacy skills at all isn't going to be particularly helpful for them. And the same with their support networks. It needs to be provided in a means that they can understand, and they need to be given the opportunity to ask questions and to seek further information if they require it. So our psychoeducation, I think, is an area in which there's a significant need for improvement. So moving on to non-pharmacological interventions or psychosocial approaches. In the general population, a range of approaches are recommended, but for those with an intellectual disability, dialectical behavior therapy is the most commonly described intervention. Positive outcomes are reported in some studies, but as I mentioned, there are significant issues in the methodology of a lot of those studies. There has been a review of DBT interventions for people with intellectual disability, and that's identified 7 studies, so not a large body of evidence. Again, all those studies are relatively weak. And what's been described is quite poor adherence to the DBT model, significant variation in the assessment and diagnosis of both intellectual disability and borderline personality disorder, differences and difficulties in evaluation, and inadequate descriptions of the adaptations or outcomes. What we do know from both clinical experience and from the studies that have been available is that DBT can make a difference, but there does need to be adaptation of the way it's implemented. People may need significant changes made in the way that interventions are delivered. So, for example, skills training sessions may need to be longer or they may need to be shorter depending on that person's ability to attend and to process information. They may need more frequent sessions because of difficulties retaining information. They certainly will require significant supports from their support network in terms of practicing and rehearsing learning in real life settings to allow them to generalize learning to different settings and to provide prompting and reinforcement of appropriate behaviors. So it's going to be very important to involve the person's support network. Group skills training can be effective and it can be done as a distinct part of DBT. So you can just do the skills training and it can be effective. In my experience, group skills training can be a very useful intervention. Individual work can also be effective, but I do think that people tend to benefit a lot more from peer interactions and that group experience, whereas individual work can be a lot more challenging. It's going to be important to recognize that individuals' cognitive communication abilities, to work out how to modify the concepts and language to appropriately fit their abilities. And it's always useful to use visual communication as well as verbal language, because even people who seem to be verbally articulate can have challenges with verbal processing and use of verbal language when they become quite stressed. And so introducing a combination of verbal and visual material can be very useful for the person in terms of integrating that material. It's also quite useful to use greater use of demonstration, practical approaches, role play and rehearsal. And I think repetition and role play is a really important part. In terms of providing that telephone coaching and support, that's a real challenge. Finding someone who's willing and able to provide that level of support, finding someone who's funded to do it, is really, really, really hard. And even those with in those people where we found someone who's able and willing to provide that support, there tends to be quite high level of burnout, and that support tends to drop off quite quickly. Where there is telephone coaching available, it's really useful to provide both the person providing the support and the person receiving the support with consistent visual cues so that people can reference those visual cues when they're working through, well, have you considered trying these strategies? What have you done already? And you can work through systematically a list of strategies that the person can attempt. And that's been one thing that was identified in a study by Liu and colleagues when they recommended that DBT should only be taken up in its whole form if there's strong long-term service system support. So if you're considering a comprehensive DBT program, you need to make sure that the adequate supports are available to be able to deliver that program, and to also consider that you may need to deliver it multiple times for it to be effective and to be sufficiently retained. These are some examples of some simple visuals that could be used for someone with a significant difficulty with verbal language or emotional recognition and expression. You could use these visual cues to help the person systematically work through how you're feeling, what have you tried to help you manage this feeling to get back into the green zone. So simple visual cues can be really a godsend. There have been some manuals that attempt to provide a systematic approach to describing DBT skills training, and the I Can Feel Good program is one of these. So the manual can be purchased from Pavilion Publishing, and it is a good attempt at providing an adapted approach to DBT skills training. We've used it a few times for several individuals and found it to be a good attempt at modification. It provides all that you would need to undertake a program of skills training with a person with a mild to borderline level of intellectual disability. In terms of other therapies, there's almost no evidence in terms of interventions such as MBT or TFP, and many people with intellectual disability are going to find it really difficult to engage with that sort of therapy. There's emerging and quite good evidence that mindfulness alone can improve the psychological well-being and be beneficial for many people with intellectual disability. So mindfulness can be a good strategy to employ, either as part of a formal program or on its own, and it's certainly unlikely to do any harm if you're using it as a standalone strategy. There have been case studies of positive behavior support that have been reported to improve the quality of life in people with BPD and intellectual disability, and have reduced the rates of challenging behavior in this population. And positive behavior support is a structured intervention that's widely used and understood in the disability sector. So it wouldn't be too difficult for disability support providers to use an adaptive PBS intervention for someone with a borderline personality disorder and intellectual disability. And certainly there's one study in particular that shows quite good response, but again, limited evidence. The selection of therapy is always going to depend on the person's individual abilities and preferences and their available supports or services. In terms of social interventions, I think this is an area where there's insufficient consideration. In general, people with an intellectual disability, like people who don't have an intellectual disability, respond well to positive social relationships and positive environments and supports. These play a crucial role in good mental health and in general quality of life. And it's really a really important factor in providing good support to someone with an intellectual disability who's also got a concurrent borderline personality disorder. Things that can be really important is accommodation. If the person hasn't got stable accommodation, it's not really going to be very effective providing any of those previously discussed psychological interventions because they're probably not going to work in an unstable environment with unstable supports. They need a stable environment and a good routine and schedule. It helps if the person has good daytime activities and stability in their general schedules. Structure and stability is a very important consideration and tends to benefit most people with intellectual disability. It's along the lines of what's recommended for people with autism, but it tends to work quite well for most people. People do respond well to structure, stability, and good, clear communication. And consider, though, that when a person's really bored and inactive, and as with most people with intellectual disability, have little to occupy themselves, that's going to create an ideal environment for people to ruminate on problems, to develop significant issues in terms of behaviors of concern, and to present with really challenging presentations. So it's always worthwhile looking at the person's social environment, where they have adequate supports, and compatibility of the supports with the person. Often expectations are mismatched. There's a mismatch between the person and their environment, and that's what's causing the person distress and causing instability in their presentation. So in terms of social supports, the benefits are it's really helpful to build resilience through improved coping skills. You can reduce stress through providing a stable, structured environment and reduce the risk of relapse or further problems. You can improve the person's confidence, improve their physical health and social well-being, improve relationships. So there's generally a lot of benefits involved with improving someone's lifestyle and social environment. There are a number of barriers, both experienced by people with and without intellectual disability. But this population experienced significant additional barriers to accessing adequate social environments and supports. One of the biggest problems can be managing expectations. Does the person know what to expect? And do they know what's expected of them? And is there a mismatch in expectations or abilities? If the person's being exposed to expectations that are not well matched with their abilities and their ability to understand and act on those expectations, then it's not going to be a good outcome. So that a brief overview of the biopsychosocial approach and some of the evidence relating to psychological interventions. And I'm briefly going to touch now on some possible interventions of which there is no clear evidence for people with intellectual disability, but which I think it could offer a good way forward for this population. So there are a number of treatments for borderline personality disorder that have been shown to be as effective as some of the structured psychological interventions such as DBT and MBT. And these include general psychiatric management, good supportive psychotherapy, and structured clinical support. And you could probably add to that nidotherapy, which is a structured environmental intervention. And so some of the common features that these approaches have to these structured psychological therapies is that there's a primary clinician and the ability to bring in specific additional supports as required. There's a structured approach to case management with a dyadic relationship and agreed goals. And the idea is to improve the person's quality of life and their ability to engage appropriately with their environment. I think general psychiatric management is probably one of the areas in which I think this offers the most promising intervention. As I said, there's no specific evidence in borderline personality disorder and intellectual disability, but the structured approach, I think, with a more pragmatic case management approach to intervention is a really good way of intervening. From my experience, where things have worked well is this type of approach where there's a real structured approach based on a good relationship between a primary clinician and the individual. There's an emphasis on psychoeducation and collaboration between the individual and their support services. And there's a goal of having a productive and satisfactory life. And these really fit quite well with the positive behavior support framework. Actually, sounds fairly similar. There's a capacity to provide flexible supports. There's not a high level of expertise required. So someone who's got good experience in psychiatric care generally would require some training, but not an extensive amount of training as you would expect in a comprehensive DBT program. It does acknowledge the role of pharmacotherapy as an adjunct. And as I said, it could be ideally, it could be undertaken by most experienced clinicians in the mental health sector. So those are just some suggestions about interventions that could be considered because their approaches tend to work quite well when you consider what the experience of what helps people with BPD and ID. In terms of specific interventions, there is a model that's quite old now. It was originally published in 2001. It's a 4-stage management model for people with borderline personality disorder and intellectual disability. And it really provides a 4-stage format about when and how to intervene. So you have at stage 1, the person would be functioning at their optimal level. And this is where you would engage them in terms of skills training, practicing soothing strategies, working up how they're going to cope. So plans for coping with specific situations, rehearsing and practicing learned strategies. And the goal is to maintain the person at this stage. So you would teach and reinforce appropriate behaviors, maintain a level of structure, and practice skills. Stage 2, you start to identify antecedents and precursors to crises. So the individual engages in identified behavior, signaling that they're going to become unstable. And the goal is to return them to their optimal level of functioning. And this is where you start to prompt them to use some of their learned strategies to engage some of the soothing and distraction techniques that they may have learned to provide additional supports and structure and to try to prevent escalation to stage 3. Stage 3 is when the person is actually engaged, also entered into crisis, and the goal at this stage is to maintain safety and to monitor for resolution. And this is not the stage where you would try to prompt them to engage in any of the learned strategies that they previously being prompted to use, and it would be a case of trying to keep them and others safe and to monitor for that resolution. And then resolution would be where they're starting to de-escalate, and the goal is to return them back to their optimum functioning. So reinstate structure, validate feelings, and try to initiate the procedures and learnings that they've used previously. I think it provides quite a good model of considering how to provide an intervention strategy. It could be combined with some of those approaches previously described. So it could be could incorporate DBT skills training. It could incorporate structured clinical management or good general psychiatric management. And you could combine those approaches to provide a good overall intervention. In terms of crisis management, I think it's important to address this in a bit more detail. It's only one component of the plan, but it's a really important one that usually in most of the management plans I've seen is missing. There's a need to try and provide de-escalation and to try to provide support networks with guidance on how to manage incidents that do occur, with the aim of rapidly re-establishing safe and effective management. It's not a treatment approach in itself. It's not a punishment. And it should be the least restrictive options. And everyone in that person's support network should be able to perform the crisis management plan and to identify when a person is reaching the red zone or reaching crisis and know exactly what to do and what's expected of them. And it shouldn't be left to someone on their first shift as a casual to be able to read through a 30-page management plan to try and work out what they're supposed to be able to do when the person they're supporting is in active crisis at that particular moment. So there needs to be a clear, concise description of what they should do in that particular situation. It's important people consistently follow the plan, and that's made clear and explicit, and that the approach generally adopted is to listen and validate without trying to intervene to actively direct the person to behave in a particular way, and to encourage support workers and carers to accept what that person says for them at that particular time is true for them at that time, and not to challenge them, to keep interaction short and matter of fact, and try to minimize verbal communication, because that person won't be processing verbal language as well as when they're not in crisis. To try and be respectful of their personal space, but also to consider whether they may need someone who's in the vicinity to help them feel safe, and to, when appropriate, to encourage them to use some soothing techniques if that person is known to benefit from those techniques at that particular time. But what's important is consistency. I think consistency can't be emphasized enough. Everyone needs to intervene in the same way each time. When that person shows signs of coming down and exhaustion, then it's important to try and reinstate that structure as quickly and effectively as possible, and to recognize that their feelings are that the person's going to need to be supported with some additional interventions to help them to be able to manage the fallout from their crises. And PRN medication may be helpful in this respect. So that's provided an overview of management strategies and treatment strategies for borderline personality disorder in people with intellectual disability. As I said, there's a significant lack of evidence and guidance, but hopefully I've provided you with some assistance in working out what may be effective and what may be possible in this group who are really challenging to manage, present with significant difficulties and experience high levels of distress. Some of the things that really need to be emphasized is that this population need really stable long-term accommodation with consistent supports, and supports that can deliver, who are able to deliver the therapeutic interventions, can effectively manage and contain risk, can provide predictability and stability. And if that can be achieved, then some people can benefit from the usual interventions with a number of reasonable adjustments. And there are a number of people who will also improve regardless of the intervention. So providing structure and consistency and support in the meantime is only going to be a benefit to that group. So in conclusion, people with an intellectual disability and borderline personality are a vulnerable and disadvantaged group with high rates of distress and disturbed behaviours, presenting significant challenges to supports and services. There are complex needs, and these people tend to present with major management challenges. There are a number of practical and philosophical difficulties with both assessment and diagnosis, and also in terms of treatment and management. What tends to be effective is a comprehensive longitudinal assessment and a management structure that focuses on a biopsychosocial framework, structure, collaboration, and consistency. Some people with a mild intellectual disability may respond to the usual intervention with some adaptation, but all are likely to respond to a structured approach. Stable long-term support, accommodation and supports are a major factor in good outcomes. And really good supported case management with a very practical approach tend to work really well in practice. And I think that brings me to the end of this presentation. Thank you very much for listening.